அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றோம், நல்லனவற்றை உள்வாங்கும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள்.
சரண்யா தேவி ப்ளீஸ் மியூட்டுங்க, மியூட் பண்ணிடுங்க.
தேங்க்யூ சார்.
Thank you, Treasurer Dr. Dakshayani. This program has been very unique since that it has had a continuous patronage from successive presidents of IAP TNSC, starting with Dr. Aram Sandil and then Dr. Ramesh and now with Dr. Suresh Babu. And I'm very sure Dr. Balashankar sir also will be equally enthusiastic about this PG clinics. And let me just tell you that this is a 99th program in this series. So next program will be our 100th. So we are going to hit a century. And I thank all the office bearers of IAP TNSC and academic coordinator Dr. Rajendran and all the other judges who have been actively involved in making this program a great success. In this juncture, I would also like to thank each and every teacher and the student who has been part of this program to make it a big success. And for the third consecutive year, we gave the best prize, and I think it was Dharmaburi Medical College which won. Am I right? I might be wrong. I think I'm wrong. Sorry. It is Mehta's hospital which won the prize for best presentation prize for last year. So congrats to them. And I hope that PGs will show more enthusiasm for the coming year. Over to our President, Dr. Suresh Babu sir, for a few words.
Good evening all, and my name is Secretary Dr. Thiru, Treasurer Dakshayani, President-elect Dr. Balashankar sir, and the Academy of Pediatric Sciences Coordinator, Professor Rajendran sir, and the esteemed judges, Professor Srinivasan, Professor Ramesh sir, Chairperson for today's evening, Dr. Akhila Ayyavu, and moderators, Dr. Soundram and Dr. Tamilarasu, and the learners, Deepa, Rajalakshmi, and Saranya Devi, and all the participants, viewers who joined online. So it is a very happy moment for us to be a part of this wonderful program which was started by Dr. Rajendran and our team in the year 2020. So it is going on for 3 years, and as Dr. Thiru told that we are reaching about 100th program. So it is a great benefit to the student community, especially the postgraduates who are participating, who are having a wonderful opportunity to learn from the esteemed team of teachers and professors and legends who are joining in this program. And I wish this topic, a very apt topic, the short stature and weight gain, selected by the academic coordinator in consultation with all the moderators. So I think Dharmaburi Medical College students are participating. I wish them a very good learning experience today. And I wish the program a grand success. And I wanted to thank Dr. Thiru for conducting this in a nice manner, especially honoring the students who have done well during our Sangamam Pedicon. And we were able to honor Dr. Ramachandran Madam and Ramachandra Mohan Madam as well as Professor Ramesh sir. We could not have Dr. Professor Srinivasan sir because he was abroad. So we will definitely honor him in another occasion. Thank you once again. And
thank you, sir. I now request our President-elect Dr. Balashankar sir to say a few words.
A very good evening to one and all. Sorry, long time I'm participating in this because of my schedule of my clinic hours. It falls on clear today. Fortunately, I'm on leave, and I never wanted to miss if I am free this class because this is a unique learning opportunity. I do not know how far the PGs recognize the importance of this scientific program because you are able to listen to the clinical discussion from the top persons in the field from all over Tamil Nadu. So that is the benefit. In the land, அவங்க இன்ஸ்டிடியூட்ல அவங்க சீஃப் அவங்க ஹெச்ஓடியும் சொல்லித்தரதோட முடிஞ்சு போயிடும். Now the stage is open to learn from the expert in the field from all over Tamil Nadu, even out of Tamil Nadu also. So in that way, this program is very unique. And the sir, Rajan sir, எல்லாரும் சேர்ந்து conceive பண்ணதான். That really I should congratulate all of you for framing such a wonderful teaching program, which is really a boon for the postgraduates. And, I can easily say if they attend all these programs under art class, then even touch the book, they will easily pass the clinical examination. That's what I honestly feel. So I wish the program grand success, and it's a very good learning experience for one and all, not only for students and for seniors like us also. Thank you very much.
Thank you, sir, for those few kind words. May now request our academic coordinator, Dr. Rajendran sir, to take over the session. Over to Dr. Rajendran sir.
Thank you, Dr. Thuru, and respected our dynamic President, Dr. Suresh Balan sir, and President 2022, Dr. Ramesh Babu, and President-elect Dr. Balashankar sir, and our dynamic Secretary, Dr. Thirumurugan, and President Dr. Dashani, and other dignitaries. And on behalf of IAP TNSC, I welcome one and all. And as you said, now this is nearing almost 2019. We have started this IAP TNSC teaching program. Now it's the 4th year. And behalf of IAP TNSC, I welcome all the judges, Dr. Ramesh and Dr. Ramachandra Mohan, Dr. Srinivasan sir, and I welcome today's chairperson, Dr. Agila Ayavu. She is currently a senior consultant pediatric endocrinologist, GKNM Hospital. More than that, she is IAP National Pediatric Endocrine Society's national president also. On behalf of IAP TNSC, I welcome Dr. Agila Ayavu, madam, and she was my senior in college also. I welcome Dr. Agila Ayavu. And I welcome today's moderators, Dr. B. Soundaram. She is a consultant pediatric endocrinologist from Apollo Children's Hospital, Chennai. I welcome Dr. Soundaram. I welcome Dr. Tamilarsu. He is currently a senior assistant professor of pediatrics, Government Medical College, Dharmaburi. I welcome sir. I welcome today's postgraduates from Dharmaburi Medical College, Dr. Deepa and Rajalashmi and Sarnya Devi. And once again, on behalf of IAP TNSC, I welcome all the central as well as state IAP members and all the delegates, all the postgraduates. Now it's over to Dr. Agila Ayavu, please.
Good evening, everyone. It's an honor and a privilege to be here today. I'm deeply thankful to the President, Dr. Suresh Balan, the former President, Dr. Ramesh, the future President, Dr. Balashankar, the Secretary, Dr. Thirumurugan, and the Treasurer, Dr. Dakshani, the academic coordinator, the dynamic academic coordinator, Dr. Rajendran. As always, you escaped my teasing in college, but it is continuing through life. And it's a beautiful relationship. Thank you so much. And it's wonderful to have Dr. Soundaram here. She's absolutely brilliant. And I'm sure the discussion today will be excellent. And we're deeply thankful to the judges, Professor Srinivasan sir, Professor Dr. Ramesh, and my dear friend, Dr. Ramachandra Mohan. And I also welcome Dr. Tamilarasu, who's the coordinator for today's program, and welcome to the PGs. Dr. Soundaram will lead the discussion. I may be popping in now and then to ask questions, but the main lead will be Dr. Soundaram today. Please, Soundaram, it's up to you now. All the best. Thanks.
Thank you. So the PG can start with the case presentation.
Dr. Deepa, you can share your slide, please. Deepa? Dr. Rajalashmi.
Yes, sir.
Hello?
Sir, it's disabled, sir. Disabled, sir.
இல்லையம்மா நீங்க இப்ப இதுல தான் இருக்கீங்க. You can hear me.
Sorry, you will be able to share now. Please try.
Yes, sir.
Dr. Agila Ayavu, actually, as a senior person, we have to make you as a chairperson, but you can lead your main discussion, please.
Doctor, can you just make it presentation mode, please?
Good evening, Honorable Ma'am. I'm Dr. Deepa from Dhanavali Medical College, ma'am.
Can't you make it full
Can you just
screen?
go to the presentation mode, please? Press F5 or the
Slideshow, ma'am. Slideshow.
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 right at the top. You have got the enable editing. Press பண்ணுங்க. அது பண்ணாத போக கூடாது. மேல ரைட் அந்த ப்ளூ கலர் பட்டன்ல இருக்கல enable editing அத பிரஸ் பண்ணுங்க.
Enable editing இருக்கு பாருங்க. அது பிரஸ் பண்ணுங்க.
Enable editing அத எடுத்து
அது ஜஸ்ட் பிரஸ் பண்ணுங்க.
சவுண்ட் கேக்குது.
Doctor, one of you can start presenting while the other tries to decipher how you're going
I'm
to
just
make
requesting
it into
for
a presentation
access.
mode.
Just accept that request. No, sorry, doctor. Just accept that request.
Ma'am, in the meantime, shall I ask the questions to the other two?
Yeah, please do. I think that's the way to go forward. Let them, one person can sort out and the other two PGs can answer
So
questions.
who's presenting now? Rajalakshmi is it? So the other two can answer. Dr. Deepa and Dr. Saranya Devi.
Yes, ma'am.
Are you there? Yeah. So first, can Dr. Saranya Devi tell me the definition of short stature? Definition of short stature.
Ma'am, height for age is less than 2 standard deviation.
Okay.
And growth velocity.
Growth velocity. Can you be a little loud? On the centile chart below, which centile you will call as short stature?
This is less than third percentile.
Yeah, so height less than the third percentile. For
Yeah,
the
you can proceed, Doctor. Now full screen. Yeah, you can proceed now. Please start your presentation.
Yes, sir. Okay, sir. My case is Akshay, 2 years old child whose informants his mother. His reliability is good. Came with chief complaints of the child is not gaining adequate height since birth.
Okay.
History of presenting illness. The parents noticed that the child is not growing in adequate height since birth. He is short comparing to other boys in same age group. He is not outgrowing his clothes. His weight gain is also low.
Okay.
Doctor, there is a bit of an echo. Do you want to shut down if you have two devices on? Can you shut down one? And can you go back to the previous slide, please? Can you go back to the previous slide? Yeah. So do you call it height in a child who's less than 3 years of age? What do you call it? Is this child is only 2 years of age, isn't so? So what do you call
Length
it?
of the child.
Yeah. So the start
Length of
itself,
the child.
so the starting itself is a little bit stuttering from the presentation to the definition to the description. Everything is going awry and it's going off scale. I think you need to take a deep breath, breathe slowly, present correctly, please. Take a deep breath, relax, and then start, please.
And the chief complaint you have to also tell about the poor weight gain. No, you've mentioned only about the poor length. So you're also mentioning in the history of presenting illness that the weight gain is also poor. So that also becomes an important thing to present in chief complaints. Okay, you can go to the next slide.
Yeah, and also you said reliability of the short stature and reliability is good. It's the parents' reliability you're talking about. So at the point when you start presentation, you should say whom you're getting the history from and how is their reliability. It is not the child's reliability.
Yes, ma'am. History of
Please go ahead.
history of presenting illness, no history of inadequate dietary intake,
Your
no history
slide
of
is not changed. Your slide is still in the previous one. Are you able to see the, yeah. Yeah, go ahead now.
no history of dietary intake, no history of chronic diarrhea or oily stools, no history of polyuria, oliguria, or polydipsia, no history of recurrent LRI, no history of constipation, lethargy, excessive weight gain, or dry skin, no history of easy fatigability or lethargy, no history of bony deformity, recurrent fracture, no history of vomiting, headache, or visual disturbance.
Okay, can you just explain each and everything why you have asked here? So what are you trying to tell by all these negative history, each and every line? Can you just tell me what you're thinking of?
Inadequate dietary intake to rule out malnutrition, ma'am.
Okay.
Chronic diarrhea and oily stools also. Stature, malnutrition to rule out, ma'am.
It is because
Polyuria.
of the gene disease, exocrine pancreatic insufficiency will cause oily stool. Okay, so it is malabsorption. So fat malabsorption you're telling by oily stools. And chronic diarrhea, so any GI illness can be there. So cystic fibrosis or anything like that, which is like presenting from infancy, you're thinking about malabsorption syndromes. Okay, so malabsorptions you're thinking of. Then third point.
No history of polyuria, oliguria, polydipsia to rule out RTA, ma'am.
Okay,
Renal
renal tuberculosis.
oliguria to
Okay.
rule out chronic kidney disease.
Yeah, that's right. Okay.
No
The other rare thing is nephrogenic diabetes insipidus can be there. That also will present with polyuria. Sometimes these pituitary stalk interruption syndromes, congenital hypopituitarism is there. No? That also will have central diabetes insipidus. So these can be the presentation. Then fourth point.
No history of recurrent LRI to rule out congenital heart disease.
Okay.
No history of constipation, lethargy, excessive weight gain, or dry skin to rule out hypothyroidism.
Okay.
No history of easy fatigability, lethargy, chronic systemic diseases to rule out chronic anemia like that.
Okay, it is a very common complaint actually. It is nothing specific, fatigability and lethargy. Okay, then next point.
No history of bony deformity or recurrent fracture. Bony deformity to rule out rickets and recurrent fracture to rule out osteogenesis imperfecta.
Okay.
No history of headache, vomiting, or visual disturbances to rule out increased intracranial pressure.
Okay, so what will increase intracranial pressure do? So if you have hydrocephalus, what does it cause? How does it cause short stature? You're thinking of raised ICT, no? So how does it cause short stature? Yeah, so it will affect the pituitary secretion of hormones. Okay.
Can I just add a point? So how many patients under the age of 2 years do you see weight gain in hypothyroidism? You just made it into a general presentation, doctor. The focus should always be appropriate for the age group. Your presentations cannot be generalized like an adult. So you cannot say constipation, lethargy, excessive weight gain. Your patient is already having poor weight gain. And why would you ask about excessive weight gain? It has to be appropriate for the patient you are presenting, and it cannot be a generalized history that you're presenting. That is where you falter in the exams also. So there is no excessive weight gain because of hypothyroidism in such a young child. It's different from that.
Yeah, we
Please
can
go
go to
ahead.
the next slide.
Past history, no history of systemic illness in the past, no history of long-term steroid intake, and no history of contact with TB patients.
So this also, like ma'am told, it is not relevant to the specific case, no history of contact with TB patients and all. Okay, so Okay, fine. So steroid intake will also affect growth velocity. So you've asked for that. There is no systemic illness to ask for that. Okay, next slide.
Antenatal history. Mother is it is a spontaneous pregnancy, booked and immunized on regular iron and folic acid supplementation. Her mother's pre-pregnancy weight is 38 kg. Weight gain is adequate around 9 kg. Antenatal scan was normal. Quickening felt at 5th month. There is no history of gestational diabetes, pregnancy-induced hypertension, fever with rash, bleeding per vaginum, or no history suggestive of urinary tract infection.
So, like, what are you expecting if you see that the antenatal scan showed short femur or something like that? They have mentioned in the antenatal scan. So, then what will you think of? If the baby's length was short in the antenatal scans itself, then what will you think of?
Femoral length is low. It indicates downs.
Actually, skeletal dysplasia, achondroplasias can have short femurs. Okay, so you will think of skeletal dysplasias at that time. And quickening and all, if it is not it was delayed or the fetal movements were poor, and now you're seeing short stature with cryptorchidism, then what will you think of? The fetal movements were perceived very less, and now the baby is hypotonic and short stature is there. What will you think of?
Spinal muscular atrophy.
In a child with this short stature, you will think of Prader-Willi syndrome. So hypotonia will cause decreased fetal movements. They'll also be short. Okay. Yeah. So gestational diabetes and all, they will all cause LGA babies only. Okay. So I don't think that is important here. PIH. Okay. Okay. You can go to the next slide.
No, before that, can I just... So why is antenatal ultrasound important? Can the PGs answer? Dr. Soundaram talked about short femur. What else will you ask for in the history? What will you look for in the antenatal ultrasounds?
Femur length.
That doctor's already mentioned. Anything else you will ask for? You would like to look at
Doppler.
Yes, please.
Doppler.
Doppler scan. Yes. What will you look for in the Doppler?
Diastolic flow, placental insufficiency.
Yeah, excellent. So intrauterine growth restriction can be made out in the antenatal ultrasounds, and you have to see whether the dating scan in the first trimester itself shows disproportionate growth or a poor growth, or does it come in the later trimesters? So extremely important. The antenatal ultrasound is extremely important. And pregnancy-induced hypertension, okay, gestational diabetes or diabetes antedating pregnancy. If the mother has pregnancy even prior to the conception, you can still have small for gestational age infants if the placental insufficiency is severe. Some of them may be LGA, but some can be SGA also. So all of these factors, each of them is important, and the antenatal ultrasound is extremely important. So what are the causes of short stature, and why did you ask for this antenatal ultrasound? You can have a mnemonic and look at it later. Please go back and read. You might have a lot of idea from that. Thank you. So, Dr. Soundram.
Yeah, I can go to the next slide.
Natal history. Birth weight of the child is 2.5 kg. It is a term baby. Birth length is not known. Mode of delivery is LSES. Indication is meconium strained amniotic fluid. Delivered at 39 weeks. Cephalic presentation. There is no history of birth asphyxia. The child was breastfed after 2 hours of delivery. No history of neonatal hypoglycemia, seizure, jaundice. No history of feeding difficulties.
So is the birth weight AGA or SGA? Birth weight, is it AGA or SGA?
AGM.
Yeah, exactly 2.5 kg is the 10th centile. So anything less than the 10th centile will become SGA. Okay, so what is the importance of presentation in a child with short stature? What will you think of if it is a breech presentation? Breech.
Growth hormone deficiency.
Yeah, so hypopituitarism children can be reach presentation. And what is the significance of hypoglycemia, jaundice?
All present in growth hormone deficiency child.
Actually, will growth hormone deficiency first cause hypoglycemia, or some other hormone deficiency will cause hypoglycemia? More important than growth hormone is what? Which will cause hypoglycemia? Adrenal insufficiency. Okay, so if it is a multiple pituitary hormone defect, then the adrenal insufficiency is more common to cause hypoglycemia. But sometimes if it is multiple pituitary hormone, in a multiple pituitary hormone deficiency, even after replacing cortisol, if they continue to be hypoglycemic, then we will think that the growth hormone deficiency is also contributing to hypoglycemia, and we will start off treatment. Otherwise, until 2 years, we will not start growth hormone. Okay, so even after replacing hydrocortisone, even if the child continues to have hypoglycemia, then we will start growth hormone. So the first thing you will think of is adrenal insufficiency, okay, causing hypoglycemia. So jaundice
Prolonged jaundice is present in growth hormone deficiency.
it is not in growth hormone deficiency. Which else?
Hypothyroidism.
Hypothyroidism. What jaundice? Is it conjugated or unconjugated jaundice in hypothyroidism?
Both.
In hypothyroidism, it is unconjugated jaundice, and in adrenal insufficiency, it is conjugated jaundice. Okay, so conjugated hyperbilirubinemia. Okay, so no history of feeding difficulty. Why have you asked? What does it indicate? Feeding difficulty.
Bladder-Willi syndrome have feeding difficulties.
So why do they have feeding difficulty?
Micronatia, cleft palate.
What is the basic thing we told about fetal movements? No, why was it decreased?
Hypotonia.
Yeah, so hypotonia will cause the poor suck. So they are not able to suck well, so they will have feeding difficulty. Okay, so that is the importance of feeding difficulty. Okay, you can go to the next slide.
Developmental history, normal, milestone attained, appropriate for age, bowel and bladder habits normal.
Okay.
Immunization.
So if developmental delay was there, would you think of something else? What will your DDs be if there was a developmental delay along with short stature?
Congenital hypothyroidism.
Okay, congenital hypothyroidism. Then
syndromic babies.
Yeah, syndromic babies. Common syndrome which causes this? Most common?
Down syndrome.
Yeah, Down syndrome. Okay. So bowel and bladder habits normal. So essentially bowel for constipation you have asked. Okay. So basically renal function and GI only again you're mentioning here. Okay. Why should you mention that in the developmental history? Bowel and bladder habits normal. Okay. Immunization, you can go ahead.
Immunization history, immunized up to age according to national immunization schedule. No optional vaccines for you.
Okay. Can you go to the next slide?
Diet history, the child was exclusively breastfed up to 6 months. Complementary feed started from 7 months of age. By 24 hours recalling method, calorie protein deficit was identified. Expected is 550 for this age. For this weight, the child is taking 465 calories. Deficit is 85 calories. For proteins, expected is 18. Child is having 14 gram. Deficit is 4 gram.
So actually, shouldn't
it is grossly wrong.
Yeah, that's what.
It's absolutely wrong. So how did you calculate calories, doctor? Calorie requirement.
We can calculate by two methods, ma'am. First by age, for up to 1 age, 1000 calories. 1000 calories per day. For every 1 year, add 100 plus 1000 calories.
So what is the expected calories for this age then? It's 2 years of age.
1100, ma'am.
But then you mentioned 550 calories.
Ma'am, I done with the method 2. It's 10 kg, 5.5 kg. It's a child of 5.5 kg, ma'am. That
Doctor, you are wrong. If you want to calculate calories based on the weight, it has to be for the expected weight for age, and for that you have to calculate calories. Nobody can be alive with 550 calories, so your calculation is wrong, grossly wrong. So it can be for a 2-year-old child, you should do the expected weight for age and calculate the calories for that weight, and that would be the expected calories for that age. It cannot be for the current weight. In that case, it is at a deficit range. You will be actually doing it almost 2 to 3 times that. If you go back and look at your calculations for nutritional requirements, it's entirely different from what you would give for the current weight. If it is a child with severe acute malnutrition or an acute or chronic malnutrition, it will always be the expected weight for age, or for the current calorie requirement, you will calculate based on deficits. So this cannot be, this is absolutely wrong. Both the protein and the calorie requirement is wrong in this question. Please go to the next slide.
Family history, firstborn to non-consanguineous marriage. History of short stature is present in the family. Father and mother attain puberty at normal age.
So if it is consanguineous parents, what will you think of?
Down syndrome.
See, autosomal recessive disorders only you will think of in consanguineous parents, okay? So Down syndrome, it can happen because of the age of the mother. If the mother is elderly, it can happen. Or if the mother has some mutations, then it can happen. So Downs is not for consanguinity, I asked you. So if it is consanguineous parents, you will think of autosomal recessive disorders causing short stature. Okay.
Okay, so I always tell students, the examiners don't try to fail you. We always try to fail ourselves. So why did you talk about consanguinity and Down syndrome? What is the type of chromosomal abnormality in Down syndrome which is inherited? Is it non-disjunction or Robertsonian translocation?
Robertsonian translocation.
So you should never commit yourself to something which you cannot talk about. You go straight forward in a normal pattern. You don't invite troublesome questions unless you know what you're talking about. So please answer Dr. Soundaram's question on what are the disorders where you will give importance to consanguinity. Yeah, if you don't know, please go ahead.
I didn't hear you.
Prader-Willi syndrome.
Prader-Willi syndrome and all is not like that. Actually, it is from the paternal gene that they get it. So it is methylation defects. Okay, so it is not because of the consanguinity. Those are methylation disorders. Okay, so basically, like Larenz dwarfism, some cases are there which are autosomally recessive. So for autosomal recessive disorders, consanguinity becomes important for us. If you're seeing in every generation the same short stature is coming, suppose the dad was short, the paternal grandmother was short, you will think of autosomal dominant disorders. So that's why you want to know how is the inheritance pattern of short stature and consanguinity also. That's why you see whether it is autosomal recessive or dominant. Okay. Okay, so history of short stature in family, what is this? Present or absent, or what you present in whom you should tell, no? Present in whom?
For mother.
Okay, mom has. Anybody else is short? Only mom is short, and how short is mom?
The mom is 134 centimeter.
Only 134 centimeter.
Yes, ma'am.
Okay. Nobody else is short. Her parents are not short. Did you inquire?
Yes, ma'am. Her parents are not short.
Okay. And mother has any other health issues, you should ask her, no? Because mother may be short and have some other disease which is going to the baby. So we need to know if the mother is otherwise healthy apart from short stature also. So did you inquire about all that?
Yes, ma'am. The mother does not have any other complaints, ma'am.
Okay. And you've done her physical examination also. In the physical examination, you'll be mentioning about mothers also, or you want to say here?
Physical,
Like mother,
other,
she proportionate or disproportionate, we should see, because you're telling only 134 centimeter, no? That is very, very short. So you need to see whether the mother is proportionate short stature or disproportionate short stature, and whether she has any other problems, health issues, which is passing from generation to generation. Okay, sometimes the mother may not have a clavicle, so the cleidocranial dysostosis will go from mother to the child. So you need to examine the mother in detail. Okay,
ma'am,
so
that is
Hypophosphatemia
not
rickets.
there in mother, ma'am.
okay, and like Ahila ma'am told, hypophosphatemic rickets also, it is X-linked disorder. So in males, is it there in the family? You can ask. Okay, so if it is there, then if the bowing of legs is there causing short stature, then you will think in lines of hypophosphatemic rickets. So assessment of the abnormal parent is also very important, not just the height. Okay,
So,
so third point.
Mother attained puberty at a normal age.
Okay, you have to mention objectively at what age, 12 years menarche or 13 years menarche. That normal may be normal for you, but abnormal for me, no? So it is always better to objectively mention at what age dad started to shave, at
14
what
years.
14 years.
14.
Okay. So when will you call delayed menarche?
16.
Yeah, so if there is no menarche by 16 years, it is called delayed menarche. Okay. Okay, you can go to the next slide.
Socioeconomic history. The child is their nuclear family living in Paka house. According to modified Kuppasamy scale, family comes under lower middle socioeconomic class.
Okay, so what does this tell us? Like, what added point do you get for a short stature child from this? So, if they're from a lower income, you will think of undernutrition, but you're telling here lower middle. So, we don't expect the diet to be very, very poor. Okay, next one. Next slide, please.
Summary, 2-year-old male child, developmentally normal, born to firstborn of non-concerned parents with the complaints of short stature noticed since birth with no significant chronic systemic illness.
Okay, so
I beg to differ from you. You said there was no measurement of length at birth. And how do you say the child was short from birth?
And the length is not known by the.
And how do you say the child is short from birth? When you sum up, it has to be, as Dr. Soundara mentioned, it has to be objective. You don't have length at measurement. You have not marked on a centile charts at birth to tell you whether this child was short at birth. So you can only say this is a short stature which you've picked up, come to the hospital with history of short stature. Or if you have growth charts, which you already got from earlier measurements, you can say, but you cannot say from birth. And developmentally normal child, you did not elaborate on various aspects of development. This child is only 2 years old, so you should have actually elaborated on each aspect of development, including social, adaptive, language, and motor milestones. Because there will be definitely would have been a delay in the motor milestones for the type of presentation you're going ahead. So there will be red flags which will be coming up in our head whenever you present a case. This child has got short height, it's not been very well growing in aspect of weight either, based on what you talked about the calories, even though you've not mentioned the weight yet. So this child definitely has weight and height delay. So there might be delay in motor milestones unless you had elaborated specifically saying this child actually attained all the motor milestones on time. I will not accept this summing up at all. This is not very appropriate for the history you had presented. Please go ahead to the next part of the presentation, please.
Clinical examination, the child is alert, interested in surrounding, no pallor, no interest.
Shouldn't they give a differential diagnosis from the history, ma'am?
Yeah. they should.
Usually they give a differential diagnosis from the history. So what are your DDs from your sum up? So you've noticed an early onset short stature. So what will you think of?
This class is being conducted so that all of you learn to get your diagnosis from your history, which will actually be extremely important in pediatrics, even prior to your clinical examination. Your diagnosis will come from the history. It will come second from your clinical examination. So I think there is no point in depending on investigations all through your career. You have to learn today to depend on the history. So that's why Dr. Soundaram is asking. You have to have a diagnosis at the end of your history, at least something you have to say. You have to give some DD at least.
The child's parents is also short stature, so maybe familial short stature.
Actually, okay. So, okay, familial short stature is 1 DD, but 134 doesn't like fit into familial short stature. I feel the mom may be abnormal. Okay. Then, second DD. Usually in the first 2 years of life,
Isolated growth
what
hormone
contributes to the
deficiency.
height? Yeah. I'm not able to hear you. You told growth hormone, is
First
it?
2 years, growth hormone and thyroid, ma'am.
Actually,
Growth hormone
growth
and
hormone
thyroid.
will affect growth only after 2 years of age. Okay, that is the common thing. After 2 years of age, only growth hormone will play a role in height. Okay, first 2 years of life, what is the major player for the height?
Nutrition. In infancy,
Yeah,
nutrition is
nutrition.
the first.
So that is the ICP model of growth. No, so first 2 years is your nutrition. After that, childhood is your growth hormone. Pubertal, what are the hormones which play a role during the puberty?
Sex hormones and steroids.
Not steroids, growth hormone and
Uh,
and pubertal hormones. Okay.
pubertal hormones.
Yeah. So growth hormone along with your pubertal hormones, which can be testosterone in a boy or estradiol in a girl, those two for puberty. Okay. So now this is a early onset short stature. So major thing is nutrition. So first thing you will think of undernutrition here in this child because weight and height both are compromised. Okay. So the other cause for both weight and height being compromised is chronic malnutrition because of any systemic disease. However, you're telling there is no history of anything. That would be the second thing. Third, there could be syndromes, but you're telling there is no developmental delay. However, we don't have any objective like milestones, so we cannot tell about that. So, anything else you want to add, ma'am, from the history sum up?
From the history, I would actually first put nutrition only, as you mentioned, because
Yes.
there's deficiency in calories and protein intake, and the child is staggering behind both in height and weight. So my first diagnosis will be dependent on nutrition, and the cause of deficient nutrition can be multitude, but first diagnosis will still be nutrition of this child from the history that they have presented.
Okay. Yeah, you can go ahead with the examination.
General examination, the child is alert, interested in surrounding, no pallor, no interest, no cyanosis, no clubbing, no pedal edema. Vitals, heart rate is 100 per minute, respiratory rate is 30 per minute, temperature is normal, BP is 84 about 15 millimeter of mercury, measured in left upper arm. It is systole and diastole comes under 50th percentile of age and sex.
So
What
this
about
is
the
a
lower
boy
limb blood
child
pressure?
or a girl child? Okay. I forgot.
Boy child.
Boy. Okay. 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 So ma'am was asking you about lower limb.
And lower limb.
What is the lower limb blood pressure?
I didn't see.
Please go to the next slide, please.
Okay.
You can ask questions, sir.
Yes, ma'am. So actually, like history, so why have you seen for all this pallor? What will you think of in a child with short stature? If you're seeing pallor, what all will you think of?
Chronic systemic illness, chronic anemias, chronic kidney disease,
Okay.
intratumoral chronic liver diseases,
Okay.
cyanosis toward congenital heart disease, any cyanotic congenital heart disease,
Okay.
fetal edema, severe malnutrition.
Okay. Protein energy malnutrition. And even CHF, congenital heart failure also can have edema, no? And
Yes,
pallor, will you see in any hormonal problem also? Pale skin? Any hormonal disorder with short stature causing pale skin? Sallow complexion? Hypothyroidism will cause pale skin, okay? So they can also have anemia. So pale skin, you have to tell hypothyroidism as well. What was the last point in that? Okay, fine. You go ahead with this. Yeah.
Anthropometry, upper segment and lower segment ratio is 1.4:1. Arm span is 62 centimeter. Father's height is 154 centimeter. Mother's height is 134 centimeter. Mid-parental height is 150.5 centimeter. Target height is 144.5 to 156.5 centimeter. Mid-arm circumference is 12 centimeter and head circumference is 43 centimeter.
So first you have to mention the height of the child, no? After that only all this should come. First height and weight of the child should come and then your head circumference should come. After that only we can interpret all this data, no? Okay, mention the height and weight first.
Height of the child is 65 centimeter, ma'am. Weight is 5.5 kg.
Okay, so centiles. Along with the height, you should mention the centile on the growth chart.
Height is percentile is the falls under below the third percentile, both height and weight, ma'am. And score is also -3 standard deviation.
Okay, actually that height SGS calculation you've done wrongly, I think. It is coming more than -3 SG. Okay, there are some Excel spreadsheets to use to calculate the height SGS. Okay, so your calculation of that SGS is wrong. It is not -3 SG, it is far below that. Okay, you can go to the previous slide. So you have seen that the height and weight is well below the third centile on the growth chart. Okay, so now go back to the first anthropometry. First slide where you mentioned target, mid-parental height, all that. Yeah. So your interpretation of the upper segment, lower segment ratio here, is it okay? So can you tell me the ratios at birth? What is it?
At birth, it is 1.7:1, ma'am.
Okay. And then?
At 3 years, it is 1.3:1, ma'am.
Okay.
At 5 years, it is 1.3. At 5 years, it is 1.1:1. At this 8 to 7 to 8 years, it is 1:1, ma'am.
Okay, 7 years it is 1:1. That is right. 3 years 1.3:1 is right. And then at 10 years?
10 years it is 0.9:1.
Okay,
0.9.
So this is proportionate or disproportionate short stature here, upper segment, lower segment ratio, yours?
Proportionate short stature.
Okay, so if you see disproportionate short stature, then what are the causes? Causes of disproportionate.
See whether it is short limbs or short trunk.
Okay.
If it is short trunk, spondylodysplasia, scoliosis, spondyloepidermal dysplasia, like that.
So you can tell the skeletal dysplasia is affecting the spine and limbs. Okay, so that can cause, like, skeletal dysplasias can affect only the spine or only the limbs, or it can affect both. Okay, it depends on which parts of the bone are affected that your upper segment, lower segment will get affected. You tell simple things. For short legs, you can tell hypothyroidism or rickets. For short spine, you can tell pot spine. Those are simpler things. Skeletal dysplasia, there are lot of varieties, and it will vary with the part of the bone which is affected. Okay, epiphysis, metaphysis, all that. So part of the bone which is affected and spine or legs which is affected, it will vary. So go with simpler things so that you don't mention it wrongly. And the other thing is, if the spine is affected, how will the upper segment to lower segment ratio be? Will it be high or low? Suppose for this child, if you're getting upper segment, lower segment ratio of 1.6:1, that means the upper segment is high, no? Then which portion is affected? Is it the spine or the leg?
Segment is 1.6.
If I'm telling for this child it is 1.6:1, then which is short, spine or the legs?
Legs.
Yeah, legs. So when the denominator is low, your numerator is going to come high. So your legs are short. That's why the ratio is coming higher. Okay. Okay. Arm span.
Arm span is 62 centimeter.
Is it acceptable for a height of 65?
Usually arm span is less than height
Okay.
up to 6-7 years.
Actually, arm span, if it is greater than 8 centimeter, then you will think of which syndrome? Here it is acceptable. 3 centimeters fine. Marfan syndrome. Okay. Okay. And father's height and mother's height you've written. How did you calculate the mid-parental height here? What is
Father's height plus mother's height plus the it is a boy child, a boy baby, so it is to add 13
Okay.
divided by 2.
Okay, fine. So target height, yes, ma'am.
Target height and rare.
Yeah, please finish.
Target height is attained from the mid-parental height plus or minus 6 centimeters.
So one is the 6 centimeter actually. So plus or minus 6 centimeters is the target height range. Okay. And head circumference, you have not written the standard deviation. On the WHO chart, what was the standard deviation?
It's also considered -3 standard deviation.
So then height, weight, and head circumference, all three are affected, is it?
Yes, ma'am.
Okay. Okay, fine. Okay, ma'am. You want to add anything else on the anthropometry, ma'am?
You always think of short trunk dwarfism or short limb dwarfism. So that is how what Dr. Soundra meant by the upper segment, lower segment ratio. So do any of you know how to measure a sitting height and how is it different from a lower segment ratio? How do you measure sitting height? Okay, just for your own measurement, I think you're going to show charts of how you measure the parents and all that. We can probably come to that later. Please go ahead and then we'll have some questions because we have some questions from Professor Ramesh on the chat box also, which I will ask after you present the next few slides. Please go ahead. So, I mean, I'll just add one point. The arm span is -3 centimeters, the difference between the length and the arm span up to 7 years of age, and then it is 0, and then beyond 14, it is +4 centimeters in boys and +1 centimeter in girls. That's a normal arm span to height difference. Please go ahead. Please go to the previous slide, please. The parents' height measurement. Okay. Dr. Soundram, you want to ask them?
So how do you measure the height? So can you tell me how to measure the height accurately?
Now for measuring the height, we have to remove the shoe socks and we have to remove the any braids is there. We have to stand straight against stadiometer, the heel, calf muscles, buttock, shoulder, and the back of the head should touch the stadiometer, and the eyes should see straight by measuring a imaginary line called Franklin line.
What line?
Franklin line.
Okay, Frankfurt plane. Can you tell me if the height measurement being done in the mother is right in this photograph? What are the mistakes in the measurement of the height in the mother?
The mother separated
Excuse me?
the foot is separated.
Yeah, so the positioning is wrong. Then next one. There are several mistakes in the measurement of height in these. In the mother, there are a few in the father. So how can you comment on the mistakes in the mother? Because this whole case presentation is revolving around short stature, so you cannot make mistakes on measurement of height. Then that is a skill you have to acquire, which can never, because all through your life, this height measurement is going to be a part of your evaluation of every child you're going to see in your life. So height measurements, you cannot make mistakes. So what are the other mistakes that you committed while taking a photograph of this height being measured in this woman? The foot is separated. How will the hands be? The hands should be with the palms facing inwards and touching the limb. The father's is also right in the front. We are not very clear whether the buttocks are touching the scale. Her head is slightly tilted upward. You're using a scale which cannot be used to measure the top of the head. It has to be a board. It has to be a fixed board. The father is standing against a stadiometer, but the mother is standing against a chart fixed on the wall. And you don't know, have you standardized this height measurement or this height chart before? And what is Frankfurt plane? Why do you use a Frankfurt plane? If you're going to touch the back of the legs to the wall, the back of the foot to the wall, the back of the buttocks to the wall, the back of the shoulders, and then the head, why do you need a Frankfurt plane then? The mother's head is tilted upward. So that means she's not on the Frankfurt plane. Frankfurt plane is a line which goes through the lower edge of the eye, through the ear, and it has to be parallel to the floor and perpendicular to the stadiometer. So if a person is heavy, muscular, with a bit of fat, then the head will tilt when they touch the back. So in adults, when you measure a height, they have to stand against the wall. For children, everything will be in line and in plane when they're standing against the wall. For muscular and well-built people, the head can tilt. So you have to tilt. You should use a board. The scale is tilted like this towards the back. That's totally wrong. This is a wrong measurement of the mother. The father also, I'm not sure whether he's not touching the back. He's a little bit away from the wall. So I'm not very clear whether he's measured rightly either. So the height measurement is wrong in both of them. Next one, please.
Yeah, you can go ahead.
Height is 5.5 kg in this child. It comes under below third percentile and -3 standard deviation. Height is 65 centimeter. It's below third percentile and -3 standard deviation. Weight for height is 73% and is also below third percentile and -3 standard deviation. Target height is 150.5 centimeters.
150.5.
That
was only 154 you told me, no?
Yeah. Plus 30. It's coming correctly.
Correctly. Okay. Okay.
The next one.
So when will you call it as severe short stature? Less than which centile? You told me short stature is less than third centile. So severe short stature?
-3 standard deviation.
It is less than the first 0.1 centile. On the centile charts, it is 0.1 centile. And when will you call it as wasting? Will you use weight or something else for wasting?
Weight for age.
Weight for length.
Weight for length.
Weight for length. So wasting is less than how much centile? Weight for length less than?
Wasting is -2 standard deviation.
Less than third centile. Weight for length you have on the growth charts, no? So if you see that the centile charts are there for weight for length. So if it is less than the third centile, you will call it as wasting. Okay, you will not use the weight. Like height you're using for stunting, you will not use the weight for wasting. You will use the weight for length. Okay, you can go to the next slide. So
So
what
weights
charts are these? What is the name of this chart?
WHO chart for weight for age in boys.
Okay, 0 to 5 years. Yeah, next.
To 5 years.
Okay,
So
now I will
suppose the
come with
child
the
was
question.
a 7 years old child, what chart you will use?
An IAP
Okay, IAP 2015 charts.
2015 chart.
Okay.
Just a minute. What about your friends? Are they online? Is your friend next to you? Can you ask them to answer the next question? Yeah. Doctor, can you go back to the previous slide? For the height? Okay. So Professor Ramesh is asking a question. Has this child had regular immunizations? Your phone is obstructing the view, doctor. The child would have gone for regular immunization and would have had at least weight measurement or some height or length measurements. Do you have any of them with you? Did you try to get it from the parents to plot it on the chart? Sir wanted to know, there would have been weight measurements and why hasn't it been? Do you have any of them? You have or you don't have?
No.
Okay, so you did not get it. They would have had their regular immunization visits and weights, no? You didn't ask for it.
Nice. I asked them that, but she does not have anything. Ma'am.
Okay, right. So a longitudinal growth chart is much more important than a one-off height measurement on a growth chart. And what is this chart called, as Dr. Soundram asked? What is MGRS? This is a WHO growth chart. You're using it in India, but you said for up to 18 years, you will use IAP growth chart. But why did you accept the WHO growth chart for children under the age of 5? India was one of the countries which were used for production of these under 5 growth charts by the WHO. So India is a participant country in that. And that is why the MGRS growth chart is acceptable in India for children under the age of 5 years. Please go ahead.
This is the height for age chart, WHO chart for 0 to 5 years. It also comes under -2 standard deviation.
So from this, you can tell the centiles only, no? You cannot tell the SG from this.
I thought I asked too many questions.
Okay. You have to just tell it is less than the 3rd centile.
Yeah, that's all you're saying in that. Then don't see the standard deviation of that growth chart.
That's so the weight for height chart, that's also concerned the 3rd percentage. Head circumference also comes below 3rd percentage.
Okay.
Now you have a child with microcephaly. Don't you think our question on development was important? So that is a child with microcephaly. So you should have had more, instead of so many negative history, you asked about no history of. First talk about positive histories. So you should have concentrated on the milestones also. Yeah, please go ahead with this chart. So can you go back to the previous chart? Yeah. So what have you marked on this?
Target height of the child. It's also comes in the 3rd percentage.
So what is the table present on the right side? What is that scale present there? Did you use it? What did you use it for?
Mid-parental height.
Yeah. So this is actually a new IAP growth chart, which has made it easy for the pediatricians. Please go ahead.
Actually, you have not commented about the anterior fontanelle, no? Is it closed or open? In a child with
Doesn't come to the examination, I think that's what.
Okay.
Interpretation weightage for this child is 2 months Height is for the child is 4.5 months. Chronological age is according to the date of birth, it is 2 years. Ma'am.
Okay. So what is the interpretation you have written? Weight age less than height age less than chronological age. What does it mean?
It's mean the child having chronic illness, systemic illness.
First is
Malnutrition.
undernutrition.
All
Child is
nutrition, all
malnourished.
nutrition.
Yeah. Okay. Suppose the child's okay. Suppose the weight age was better than the height age, then what will you think of? The weight age is more than the height age. Chronological age. The weight age is more than the chronological age, and that is more than the height age. So the height age is more compromised compared to your weight age, and what will you think of? In simple terms, if your weight age is better and your height age is lesser, so what will you think of in those circumstances?
We've got only, I think, 15 more minutes to go. I think we'll just go ahead.
Okay.
Yeah. Doctor, complete your presentation. But what Dr. Soundaram wanted to know was you have a extreme compromise of height age compared to weight age. So you have to think of hypothyroidism and other endocrine disorders. Go ahead with the next part of the presentation.
Head-to-toe examination, frontal bossing was plus, eyes, ears, nose are normal, voice is normal, dentition is good, fundus, no papilledema, oral cavity is normal, there is no cleft lip or cleft palate.
We'll finish up the presentation, then we'll ask a lot of questions.
No skeletal anomalies, no kyphoscoliosis, no obesity, forearm, arm, hand are normal, skin is normal, there is no neurocutaneous markers, hair and nail normal, there is no asymmetry of body, and external gender of the baby, penis is normal in length, bilateral testis descended, which is present in scrotum, systemic examination, abdomen soft, non-tender, no organomegaly, CVS S1 S2 plus, no murmurs, RS bilateral RNK plus, no added sounds, CNS tone normal, there is no focal neurological deficit. Summary, a 2-year-old developmentally normal child, firstborn of non-consanguineous marriage with short stature, noticed with no significant chronic systemic illness. On examination, the frontal bossing was plus with proportionally pathological short stature, severely shunted and wasted with normal genitalia and no significant chronic systemic illness.
What are the measurements or what are the other clinical examination you have missed in this patient? What are the important aspects of clinical examination in a patient with short stature? First is anthropometry. Height, upper segment, lower segment ratio, or a standing height to sitting height proportion. Then you will look at head circumference, weight centiles, and then you will put both the palms together and hold the hand like that to see inequality between both because you have extreme short stature. The differential diagnosis can be Silver Russell syndrome. So you can have hemiatrophy or hemihypertrophy. So you have to keep both the palms to see the difference between both of that. And then you will keep the thumbs like this to see if you have proximal shortening or the distal shortening. And then you will put the hands by the side and look at your cubitus valgus. Because you're looking at Turner syndrome also. Then you will see, make a fist, look at the other side. Ask the patient to bend, look at the back. You have to look for scoliosis, kyphosis. At the same time, you have to look at the skull, anterior fontanel, posterior fontanel, Vermean bones. And then when you put the hands together, it's not only Silver Russell syndrome, cleidocranial dysostosis will also be picked up there. And then when you bend forwards, you can look at the spine. So you actually missed most of the examination of a short stature patient in this. And I'm not at all a big fan of talking about S1, S2 plus. Do you mean to say we are studying in +2? You have to say it is the trachea is in the midline, the apex is in such a position. The patients on inspection, we did not see any specific thing. And then you auscultated, the first and second heart sounds are heard normally and regular in rhythm, character, and then you will say there is no murmur. S1, S2 plus and murmur is absolutely not acceptable at this level of clinical examination for a student of MD. Same thing holds good for respiratory system. You have to talk about the position of the trachea, equality of both halves, the back, then the type of respiration, palpation, and then an auscultation. Then you talk about abdomen, inspection, palpation, and percussion, at least basics. And then the neurological system, you should have talked about hypotonia, because from the beginning, Dr. Soundaram has talked about hypotonia. You have talked about Prader-Willi syndrome. And then you have not talked about the tone. You've not talked about the power. You've not talked about the reflexes. So this is a very, very basic clinical examination and not very well done. I'm not very happy about the presentation of a short stature. This was a simple case. I thought you will actually just ace through it. But I think you have to go back and revise and make it better.
Sorry.
So what is your diagnosis? From your history you gave, it's probably a malnutrition. That's what we helped you with. So what is your diagnosis now? Doctors first, keep your mind open. Not all short stature, because we are an endocrinologist, is growth hormone deficiency. Growth hormone deficiency is the least important diagnosis or the last diagnosis you would think of after ruling out everything else. Dr. Soundaram, you can lead the discussion.
Yes, ma'am. So actually, as we discussed first itself, your height, weight, HC, everything is compromised. Okay. So you will think of growth hormone deficiency only when the height is more compromised compared to your weight. And here HC will be normal in most of the situations. Okay. So in a child, that's why I asked you about height age being more compromised than the weight age. Only if the height age is more compromised than weight age, you will think of endocrine short stature. So endocrine short stature can be growth hormone deficiency, hypothyroidism. Those are two common things. Apart from that, Albright's hereditary osteodystrophy also can be there, and Cushing syndrome. Okay, so these are 4 causes of endocrine short stature. You will think of only if the height is more compromised than the weight. Here, if you see, the child's weight age was more compromised than the height age. So more we will think in lines of undernutrition only here. Okay, but you're saying that there is microcephaly also. So if microcephaly is also there, then I will think of syndromic causes. And one other thing is like baby was normal at birth, so we will not think of primordial dwarfism. Otherwise, if the baby was small at birth also, then we will think of primordial dwarfism, where all height, weight, and HC are affected. Here, when height, weight, and HC are affected but normal at birth, then I will most probably think of syndromes. I will not think of primordial dwarfism. So anything you would like to add, ma'am, in the diagnosis? So growth hormone will be the last, as ma'am told. We will not think it of first, that too in under 2-year-old children. Okay, so under 2 years, nutrition is the first.
Yeah, so you'll have to remember the IGF-1 is actually more prevalent, and effect on height will be after 2 years of age. But in severe compromise of growth hormone, you might see it early. In this child, because Silver-Russell syndrome can be an extremely important, but as Soundaram mentioned, there should be an intrauterine growth restriction, which is progressing on to postnatal growth restriction. That can be both primordial dwarfism and Silver-Russell syndrome. Malnutrition is an important part. You should have asked about, but you did mention that the mother gained 9 kgs during pregnancy, which indicates her nutrition was good during pregnancy. So this is probably a postnatal malnutrition. I would still go with malnutrition first rather than a diagnosis of a growth hormone deficiency. I will first sort out, because you are grossly deficient in the proteins and calories. Was there any reason for this child not to eat well? though I think it was too superficial a questioning because your clinical examination did not substantiate the amount of effort put into the examination of this child. So I would actually doubt your history on how you asked about the nutrition. I would still go back and look at the nutrition, try to see why there was malnutrition. Is there any other chronic illness you missed before I think of endocrine causes and growth hormone deficiency as a cause of short stature in this child? My first focus would be actually on nutrition and then syndromes, as Dr. Soundar mentioned, because you can have microcephaly because of severe malnutrition, but then this child could be syndromic also, but your initial birth history was about with a weight of 2.5 kg is the one which is misleading us everywhere, but then it can still be right. We may be missing something somewhere. It can still be a growth hormone deficiency, but that differential diagnosis will come further down on the list when you evaluate this child for short stature. Yeah, so.
Yeah, please go on.
Lab investigation, PBC peripheral smear, RFT, LFT, thyroid profile, and urine protein and bone age taken.
So bone age, how do you assess? Using which charts you will assess bone age? Do you know the name?
Of the left, by
Okay, you tell me which hand. Tell me.
By taking X-ray of the left hand and wrist.
Okay, left hand with wrist. Which view? View.
AP.
Okay, AP view. So why are you using the left hand?
It's a non-dominant hand.
Okay.
The bones.
Any other point why we are using the left hand? Because the reference atlas which we have also is from the left hand only. Correctly, as you told, it is a non-dominant hand. Okay, so which atlas do we use to assess the bone age?
Files atlas.
Rulage and files atlas. Okay. Anything else you know? Okay. Okay, that is enough.
Tanner and Whitehouse.
Okay, Tanner and Whitehouse. Okay. Yeah, go ahead.
When you talk about investigations in an exam, you will say, I will do a peripheral smear and look for any anemia or a bicytopenia or a pancytopenia. I will do a renal function test to assess the renal dysfunction because renal failure can be a cause of short stature. I'll do a liver function test because I'm going to look at the protein in that because I'm still keeping malnutrition as a part of my, or is there a liver dysfunction which pertained or was important for this child to develop malabsorption? And then each of the investigation, when you talk, you have to talk like that. Why you did each of them, and you have to justify in your exams. The urine analysis, you will look at the specific gravity, specific gravity, and everything else. Bone age, you finished. Next slide.
For confirmation test of insulin-like growth factor binding protein P and growth hormone stimulation test.
Actually, this random growth hormone level has no value at all. Okay, so after ruling out all systemic disease, if we are thinking last as growth hormone deficiency or insensitivity, we will do a growth hormone stimulation test directly. We will never do a random growth hormone level. Okay, and IGF-1 you have skipped here. Did you have any reason to skip the IGF-1?
IGF-1 is in children more than 3 years.
Okay, so less than 5 years, usually we avoid IGF-1 because the nutrition per se can give us low values of IGF-1. It may not indicate the growth hormone levels. So IGF-BP3 is preferred in younger children. Okay, so what are the common stimulants you use for growth hormone stimulation test? Any two can you just name?
Oral clonidine and IM glucagon injection.
Okay. Yeah, you can go with the next slide.
Investigation of this child, HB is 10.6 gram per deciliter, hematocrit is 31.8%, total count is 9,000 cubic millimeter, platelet is 3,44,000, urea of this child is 27, creatinine is 0.4, urine protein of this child is normal, total bilirubin is 0.6 milligram per deciliter, direct is 0.4 milligram per deciliter, alkaline phosphatase is 230 international unit per liter, Total protein is 6.1 gram per deciliter. Serum albumin is 4.3 gram per deciliter. Serum calcium is 10.1 milligram per deciliter, and phosphorus is 3.5 milligram per deciliter.
Okay. So the baseline investigations are normal. Next, what
Normal.
do you do? Yeah.
After that, I take thyroid function test. Free T3, T4, and TSH are within the normal range. And discuss with bone age. It is 2 corpal bones are visible. So 18 months.
Actually, bone age, it is not very accurate in less than 2-year children. Okay, so we cannot exactly comment on the bone age. Okay.
Yeah, the height age is less than bone age is less than chronological age.
I just have a funny remark to make. You talked about Grulich and Pyle charts, Standard and Whitehouse charts, and then you go back to looking at the number of wrist bones again. You have to remember in the bone age, it's actually the terminal phalanges which have the most value. And then as you go proximally, it places lesser and lesser value. So the distal part has the most important correlationship with growth. But as Dr. Soundaram said, under 2 years is difficult. Even 2 to 5 years, Standard and Whitehouse charts can be used. Beyond 4 years is where I will actually be dependent on Grulich and Pyle charts. So you cannot look at risk groups. Yeah, next point. Next slide.
Yeah, next slide.
We took a random growth hormone level for the child. It is very low. By confirming, we have to take growth hormone stimulation test. That is not done in our institute.
Random growth hormone, don't even measure and waste the money. If
I'm
you
sorry
want
to bother you. We are just coming to
Finish
the
it.
end of another
Yeah.
5 more minutes now.
We'll finish off. Don't do random growth hormone. Do a clonidine stimulation test. If you don't have anthropometry is sufficient enough to diagnose significant short stature who deserves a growth hormone. In that, growth velocity charts are the most important ones, which will play a huge role, but in a little bit older children. So just using a random growth hormone level and to try to say it is growth hormone deficiency is not actually appropriate. MRI brain, you should have looked at even the eyes if the child was young itself in the clinical examination, because septo-optic dysplasia, you will have this diagnosis. That's an important clue for multiple pituitary hormone deficiencies with hypoglycemia and prolonged physiological jaundice in the early part of the examination. I think Dr. Soundaram, you can sum up.
So, like only the mistakes you want me to tell, ma'am, like or the diagnosis?
Give them their strengths first and then
Okay,
their
strengths
weaknesses.
first. Okay. So actually, strengths, like the anthropometry, you have calculated the mid-parental height, upper segment, lower segment, and all that was good. But initially, you have to put the height and weight first, and then the rest of it calculation was done well. But the height measurement has to be improved, like how ma'am told you have not done that accurately. History wise, also a lot of things were missed. Like we told you, the developmental milestones all have to be concentrated when there is a microcephaly. Apart from that, examination or like detailed systemic examination, because we are thinking that weight and height are compromised, we have to definitely rule out a systemic disease. So detailed systemic examination also is necessary here. Okay, so everything I felt was very brief. So everything has to be in detail here. Okay, so that I think you have to improve on. And as we have told you, don't ever do a random growth hormone level. If you don't have, then you can refer to a nearby institute for the clonidine stimulation test. Okay, so first you have to concentrate on the nutrition and systemic diseases in this case, I feel.
Thank you very much. Any questions you have for us? Students, do you have any questions
Hello?
for us?
Madam, I've got a doubt. Is there any, did they mention about any facial features, dysmorphism?
Frontal crossing only is there, sir.
Ma?
Frontal crossing is only is there, sir.
Better you mention Mayada dysmorphism, because this is likely to be some syndrome or something. Yeah. So better to see. One question I have got for endocrinologist. When do you get the typical phases of hypothyroidism, madam? In any child with hypothyroidism, the typical moon phase triangular face and all. At what age?
Severe hypothyroidism, by 2 to 3 months, 2 months and all, you can start seeing them.
Typical faces.
Yes, yes.
Thank you. Thank you.
Thank you very much, ma'am. Dr. Island, sir. Okay. While we wait for our academic coordinator, my
Dr. Tamilarasu, he has any points to raise or anything?
Yes.
Madam, this child is it is very unlikely to be a malnourished child, madam. As far as we see the child, even though the parameters are less, but it is disproportionate to the clinical method, madam. We had the video, but
probably
put it in the.
Dr. Deepa, can you stop slide sharing, please?
Okay, sir.
Before we answer Dr. Tamilarasu, sir, any questions from Dr. Ramesh and Dr. Srinivasan, sir?
Madam, as Dr. Valasankar said in the beginning itself, I think if I follow all these discussions, PG discussion on alternate Saturdays, it will be a good exercise for them to face the examination. And I must confess that this presentation of the students was not up to the mark, because it looked like an undergraduate level presentation, not like an MD presentation. And though Dr. Soundaram was conducting in a non-threatening attitude, they were unable to answer most of the questions. And Dr. Agla Madam pointed out rightly the glaring mistakes like growth and development, anthropometry, nutrition especially. These are all bread and butter for a pediatrician, and it is very special for pediatricians. So you cannot afford to make mistakes in nutrition, expected calories, proteins. All these are very, very important. At least the students might have got the help of supervision of a faculty member, so that those mistakes could have been corrected, because so many people are seeing all over India. They are seeing, even they don't actively participate, they see the YouTubes and learn by that. And this short stature is one of the very often discussed in the PG clinics. At least in the last 2 years, Dr. Rajendran and Tirumural know 4 or 5 times most commonly discussed the short stature. And it is not discussed in the classrooms, because we don't have endocrinologists. Senior people like Agla Madam and Soundaram are not there in every medical college. So they should make use of this option. That's my observation. Better luck next time for the students. They must go well prepared for the examination. Though the moderators and the chairperson are very kind and soft mannered, the examiners will not be so kind in the examination. Thank you, sir. Thank you. And the fontanelle, they didn't mention the fontanelle, madam. Definitely they should have mentioned about the fontanelle.
Srinivasan, sir. Sir, you're muted, sir.
Yeah, I am also not very happy with the presentation, but don't get disheartened. This is the way you present, and then you come to know your drawbacks. You can always improve, and of course, the only way to improve is to constantly come and present cases, not only in this platform, but in your own hospital. You can yourself, among yourself, you can present. Many times you have seen, no, a senior PG will be teaching undergraduate PG. So presentation is very important, constant presentation. And then, no, that time you will not get offended. But when a teacher says you haven't done well, definitely will be upsetting. But when your own colleagues, senior colleagues, they are trying to help you, I think that is the only way we can improve our clinical presentation and clinical skills. Thank you so much.
As Madam Agila said, they should give a diagnosis at the end of the clinical presentation, first at the end of the clinical examination, finally after the investigation. They should be able to tell the provisional diagnosis. And most of the time, we don't have access to the investigations in the examination. So you should definitely make a diagnosis, clinical diagnosis. That's my opinion.
Yes, I also want to reiterate what Professor Srinivasan sir said. Don't lose heart. Chittiramam kai pazhakkam, sentamirum na pazhakkam. You keep on presenting, your presentation skills will keep improving. All of you are brilliant people. You will all do well. But anyway, you needed a bit of roasting today to start off well in your progression in your career.
No. We have to tell you where you are, so that is in your own interest. Yes. We don't want to say, everything is nice. So there is always scope for improvement. Yeah, even Now I am attending all these PG classes because I learned a lot from all these people.
Practice makes perfect. You learn by making mistakes, and once you learn by making mistakes, you will not repeat the mistakes again. At least in the examination. All the best.
All the best.
Yeah, thank you.
Luckily, these questions were not asked to us. Otherwise, probably we may not have answered all the questions Dr. Ahilaya was. So naturally, see, there is
I
always
actually
only
held back on my tongue about methylation and all that because I thought they will be terrified once I start on methylation.
yeah. No, 50% only is the pass mark. It's not that you have to get
You don't have to answer all
80%, 90%, but you must try to get into that above 50% mark. Okay.
I always say
kindly,
that if you answer 50% of the questions, you are likely to pass.
Always present cases to yourself and then you try to improve yourself. That is the only way we can improve ourselves. That's the only advice I want to give. Yeah, thank you.
You can make mistakes, but not blunders.
Madam, Dr. Aguila உடைய வாய்ஸ் கேட்டோன்னா அந்த பொண்ணுங்களை ஸ்டம்பிஸ் போயிடுச்சுங்க. அதனாலதான் மெயின் ரீசன். கணீர்னு பேசுனீங்களா அதனால அப்படி பயந்துருச்சுங்க.
இல்ல அதெல்லாம் ஒண்ணு கிடையாது. She is very mild and soft. Okay. நல்ல கிண்டல் எடுக்கிறாரு.
Emphatically she is telling that's the way to drive the point into the students.
Okay, on behalf of IAP TNSC, I thank all the judges and as well as today's chairperson, Dr. Aguila. She's a well-known teacher and is usually that she'll give a clear-cut message. I have seen many of her classes also. She's a very good teacher also. And I thank Dr. Aguila Iyavu. And actually, after a lot of difficulties, we got her appointment. I can say that appointment only because she was busy.
Yeah, good beginning.
Yeah,
good beginning. Sir, you look another 10 years younger, sir, Rajan. I want to make that comment also.
Okay.
He's always with the youngsters. That's why he's looking young.
Thank you, Soundaram also has done a fantastic.
I thank Dr. Soundaram. I think she has done excellent work and she has a nice case discussion also. I thank all the postgraduates as well as moderators who has done very well. And it's definitely it's a short case is long. They can use as a short case as well as long case also both in exam purpose. And more than that, it's endocrine aspect. I think Dr. Aguila has discussed very nicely, and Dr. Soundaram also. I thank our dynamic secretary, Dr. Tirumurugan Saran, and he has 24/7 always help us to make this program going on. I think the next program maybe century. I think we'll celebrate differently. I think. Okay.
Thank you very much, sir.
Thank you.
I mean, I think
all these things are available on the YouTube. Okay, all the previous presentations. So whenever you have time, you go to YouTube and then listen to each and every question which is being asked. So Dr. Tirumurugan and Dr. Rajan made it available. And of course, that is one thing which is available nowadays. Those days we were never having all these luxuries. But only thing you must make use of it. Yeah, thank you.
So thank you very much. I think for any member of the PGs, probably they should watch a 3-minute segment of Dr. Aguila Iyavu talking through the examination of a short stage. I think that pretty much summarizes the whole class. So thank you very much, ma'am. It's something which often gets missed by most of us general pediatricians. So thank you very much, and I thank our moderators for the day, Dr. Soundaram, Dr. Aguila Iyavu, Dr. Kamdarasu. For moderating session. My special thanks to our judges, Dr. Srinivasan sir and Dr. Ramesh sir, and also to the PGs. If I were, I can only confess that if I were in your shoes, then probably I would have got battered even more than what you did. So don't worry. So thank you very much for everyone and all, and hope to see you again in future. Thank you. Bye.
Thank you. Want to see your smile. We want to see your smile. The students smiling before we leave. Otherwise, we'll feel I will not get sleep. Okay, take it in the positive sense.
Or smile பண்ணுங்க.
Thanks, ma'am, sir. Thank you for guiding us, sir. Thank you, sir.
Thank you, Mr. Good night. Bye.
President, well done.